Thank you for your great presentations. And now we are open for the discussion. I don't know if there is any question.
Thank you very much to you both, and also acknowledging that Maria Jose had already prepared the session regarding the status of quality of life in people with HIV in Spain, and she unfortunately is not here with us. But I would like to ask you a question for each. To Jeff, quality of life is like assembling different pieces from different parts regarding health and also regarding stakeholders into the well-being of the people with HIV. Which is the role of the community, and which should be, if you have examples, or if you feel that there would be potential ties that do not exist yet. And to Megan, we acknowledge the value of PROMs and PREMs, but regarding the clinical perspective, I have to tell that it's hard to find the right PROMs. Maybe there is none, and you have mentioned that there is no consensus, but also because you are asking the patients to deliver some information, questions regarding privacy legally, and also questions regarding how to manage this information, because it is not only to gather the information and to keep it there, but to analyze and probably to respond to those patients showing needs.
Shall I start?
You good? Yeah.
Well, thank you very much for raising the important issue of community. And indeed, it's a pity that Maria Jose Fuster's not here with us to give us the update on the situation in Spain. I think the community plays an absolutely essential role in navigating the services. So they help in keeping appointments, in adhering to medication, in addressing social welfare issues, in addressing social isolation. There are support groups across Spain and in every autonomous community, as you well know. Unfortunately, HIV, given the stigma, the discrimination, and often the many appointments that are needed for someone living with HIV. The good news is they're aging. The bad news is, we all will die of something, and people living with HIV will often develop those comorbidities earlier. So the community, the peer networks, the peer support play an absolutely essential role in that kind of engagement with you all in the healthcare centers.
Thank you.
Okay, so so you note that it's difficult to select the right tool, and I think, as I said, there's almost too many tools to choose from. There's a smorgasbord of options, and that can be difficult. I would say, particularly at the clinic level, there is one quite good tool that's been recently developed called Positive Outcomes. There are others available, but that would be a tool that is specifically designed for that patient-clinician interaction. That would be a tool that is used perhaps the day before or the week before the appointment for the patient to fill out beforehand. It's really designed to help the patient reflect and focus on the areas that are specifically relevant to them, and then to guide that into a patient consultation, which I know can be very short, so you have to really focus that time. One thing that tool in particular found is if you don't have some sort of questionnaire to guide that at the start, patients can attend the clinic and kind of have the white coat syndrome or kind of sort of panic. Because if you say, is everything okay? How are you doing? Mm-hmm. People go, fine, I'm okay. It's hard to remember in that moment. Yeah. So that's an example of a tool and a use of that tool, which is really important to focus that consultation on the areas of need. And as for the collection of data, I think it sounded like you're talking a little bit around information governance, and this is a really important area. So I think when a tool like that is used to guide the patient consultation, that is a data collection that is within the use of the clinical purpose. So I think it's seen, sorry, go.
No, my question is
Oh.
that everything that goes within the clinic, obviously it's just behind the door and close to the hospital or the HIV unit. But when you may be promoting tools that may be used outside the clinic and may be exposed to others, my question was whether there is any kind of legal issues or privacy considerations.
I mean, it is challenging because it kind of depends what the purpose is. So as I say, in the clinical, that's protected. If you want to analyze that data, you almost always need ethics approval for research if you want to publish. And that adds a layer of complexity, which is always very difficult. Yeah. At this national level, and I do endorse actually having some sort of national, quite high level structure for collecting this data. At the national level, where we use it in the UK, we have one overarching ethics approval for this, but we can then deploy surveys at the clinic level, which are approved. We also collect that data anonymously. And so within that ethics framework and within that analysis and publication out in the surveillance systems, that's then protected. Because yes, it's very important to protect people's privacy, and especially at the government level, it's always been very important for us to make sure people feel safe to report things like migration issues or drug use and things that could otherwise compromise them. So if you're using it at a higher level outside, anonymity is very, very key for our purpose, yes.
So thank you for being here and for your super presentation.
Thank you.
I would just add to that. I think of it a little bit in two ways. One, as it's like an expanded case history, and like Megan said, it's governed within the specific hospital or clinic protections. But I also think of what's notifiable. So certain comorbidities would be notifiable, and would a low reported HRQOL one day be something that's notifiable, even just in the aggregate, the total score from one of the many tools, or even the score, from an entire hospital or clinic, and not reporting, an individual issue that may be difficult. And I think Spain, is a country that's really able to lead the way on this. I've also worked in Eastern Europe, where there's just no way in certain regimes people are going to report injecting drug use or undocumented migration issues, for example.
Yeah. I'd like to make a comment about that. You talk about the tools that we can use, like paper, electronics, and all this, but some patients, they say they don't, because electronics, I think, is the faster, is the easier, because we really don't have time to take care of all the comorbidities and everything in the clinical practice. But some patients say, I don't want to have anything in my mobile, any app saying it's related with HIV. So that is a problem. I don't know if with, nurses, help of nurses, or maybe NGOs that you say before integrate in the hospitals, or paper. I don't know what is the best way to do it.
You can start now, Ed.
Yeah, so this was quite a big area of our formative research for the survey, because, of course, if you go one route, you could seriously bias the data you get, and that makes it sort of useless. And so we did quite a lot of research with people with HIV to understand what method is the best. And we actually found it was very interesting. We said some people really preferred paper questionnaires, and they said they would never do an electronic survey. And some people said they would only do electronic survey, and they wouldn't do a paper survey because it was onerous, and who uses paper anymore, and and there's an age differential there for sure. But we also found, say, for example, women and people of Black African origin, and people who maybe have and older people and people with access needs would not fill an electronic survey. So I would really be, so what we did in the UK is we offered both options.
Okay.
And through that we're able to meet the needs. I understand it's not always possible, but for me, if you get 10,000 responses, but they're all from one demographic, then your data is not useful. So you have to consider the needs and the preferences of your population. And I would definitely say, people think paper is very old-fashioned, but actually a lot of people like a pen and a paper and having that sort of put into an envelope and it's very confidential and it goes into your clinic. So I think you have to ask the people, the population that you are working with, how they like to be surveyed. Ask them about confidentiality, ask them about privacy, ask them about preferences.
Okay.
I would just add to that I think we need to differentiate between a longer survey, and a national sample, and a shorter survey or tool that you might be doing just in your clinic, where you're asking 5 questions or 10 questions. And in that clinic, then it's not an issue of what's on your phone, it's what's in front of you. And you can have a tablet that is provided while they're in the waiting room, or it could be a piece of paper. And such a clinic kind of screening tool also can serve as an icebreaker. So instead of the sort of, hi, how are you? The next question might be, I see, you've mentioned that you haven't been sleeping well in the recent weeks or months, or you've had some stomach pains, and tell me more about what's going on. And then you've already entered into important issues that could also, be signs and precursors of an actual comorbidity.
Dr. Bernardino.
Thank you for the presentation. I have a question. I'm a clinician, and I think this is very, very important to measure the PROMs and PREMs. But regarding, and specifically the general quality of life PROMs, it's quite important to make comparison between people living with HIV and the general population. But regarding PROMs, specifically for HIV, I probably am wrong, but I have the feeling that they were based in the 90s and in the early area of HIV infection, and they focus on symptoms and side effects of antiretroviral treatment that they are not really true nowadays. So, is there any research initiative to make or design new PROMs specifically for HIV-infected people living with HIV? Because you have said before that it's quite important to be reliable, so to test and validate it, and to measure the change in these PROMs over time. So I think mostly of the specific PROMs for people living with HIV are a bit old-fashioned.
Do you want me to take it or you take it?
You can start.
Yep. Yeah, I think, so that is true to a large extent, that a lot of so when we did our review of the existing tools, quite a few do focus on side effects to treatment and medication, and other things that may be related to late diagnosis and immunosuppression. I think there are, so I've been out of the loop a little bit for 3 years, so it may be that there is something more recent, and Jeff may know. But I know that WHO Qual had revalidated and updated their tool, I believe, more recently. And there's also tools like FAHI, which is Functional Assessment of Quality of Life. So there are a couple of tools that have been actually developed late 2000s, early 2010s that have come through being much more relevant to now. Now, do we still need to ensure that we have tools reflecting patients' needs and continuing to develop those, and we can retire these old tools that are no longer relevant? Yes. I don't know right now of any initiatives that are doing that, but maybe Jeff may know something more recent.
Well, I'm thinking of the work of like Richard Harding and colleagues to develop a PROM that's really fit for purpose, and the work we've been carrying out with Maria Jose Fuster to develop a CST HIV, a clinic screening tool with just around 10 questions that you can use in your clinic that really reflect the current reality, which is that you're probably virally suppressed, you probably have other issues, and what are those important issues? And that was a co-created tool with healthcare professionals from across Spain, but also people living with HIV. So that's going to be tested out now in some hospitals, tested out electronically, translated into a valid translation into Italy, and tested out there as well. So there are some initiatives, I think, and there are some shorter, as Megan mentioned, more general tools that can be used. But I think, as I mentioned, until WHO agrees on really what everyone should be using, we should be using validated and probably short tools at the clinic level and longer tools when we're carrying out national surveys to understand the general domains where there are problems.
So talking about PROMs in clinical trials, we've seen more and more recently, and they are quite focused on the comparison of drugs, even in a double-blind fashion. Do regulatory agencies care at all about PROMs in clinical trials?
Well, it's hard for me to speak on behalf of the regulatory bodies, but I think at this stage in the development of antiretroviral therapy, it's unfortunately, I would postulate that it's probably less of a priority than the actual effectiveness. So, so it's really the only difference between some of the treatments that are simply very quickly, as you know, suppressing the virus.
Okay. So 117, tools that we have. As always in medicine, if you want to test something, you need a gold standard. So how do you resolve that conundrum? What is the gold standard that you are going to test all of these 117 tools against?
I don't know is the answer. It's really challenging. I think through the literature, some tools have emerged, maybe not as a gold standard, but as a widely used tool. So one of those that we use a lot, that I've used a lot, is the EQ5D, okay? And this is a generic tool. It's a short tool. It's very easy to administer. And I think a lot of instruments get validated against that. But it doesn't cover all the different, it's not, because it's short, it doesn't allow you to go into much detail. However, it's very easy to administer, and there are, because it's used in general population surveys, you often have a general population comparator. So I think that is functionally the gold standard against which many countries in Europe and many researchers are using to compare, because it's used in almost all countries in Europe on some level, and they'll have a general population reference. But I have a love-hate relationship with EQ5D. I don't always think it tells us what we want it to tell us. And I think, another key difference is if you're comparing to the general population, the age and sex structure of the general population is quite different to your HIV population. So there are challenges in using those generic tools and comparing.
I would just add, and well, I also have that same love-hate relationship with EQ5D. I mean, it's clearly not fully fit for purpose, but it's useful because it's so well translated. We have so many studies using it and so much data. But I just wanted to really, refer to comparisons with the general population, because we often think, well, we need to compare with the general population. It's important, but even if a particular population of people living with HIV is scoring higher than the general population, that doesn't mean the story ends, because they're in a different situation. They are living with HIV. They're living with the daily medication. They're dealing with the social isolation, the backlog, or maybe even current situation of stigma and discrimination. So they also need more support. So it's really, it goes back to what I raised around equality and equity. I mean, there's a huge inequity and a huge deficit for people living with HIV, even if they're on, fully effective treatment. So these tools can help us, with what more we need to do. But I'm not sure of the value of always just comparing back to the general population.
I might just, sorry. You made me think of another issue, which is essentially also, You can ask your short questionnaire, and maybe that's all you need if you are very time limited, but I would recommend, not asking that in isolation. Have other questions that support those, and those don't necessarily have to be validated. I didn't show the detail, but presented the needs assessment that we came up with in the UK, which asked about the healthcare needs, asked about the social care needs. Okay, that's not a validated tool, but that is a really effective way, an efficient way to collect information about things like need for drug and alcohol services, need for weight management service, need for help dealing with loneliness and isolation, for food security, for housing, and things like that. And I think if you have that sort of base information as well, you can pair that with the quality of life data, and I think then that gives you a much broader understanding of the needs of your population.
So, quick questions. As a clinician, my request or a plea will be to have some kind of guidelines with a tiered approach that say how much time you have for patient in your clinic. You have 20 minutes, you can go to this EQ 5D. You work, I don't know, Switzerland, and you have 1 hour per patient. You can. So, are you in the process of, writing any type of guidelines with just to help clinicians to pick, the right questionnaire for depending on their clinic business?
Yeah, I mean, there are initiatives, but that's the next step. I mean, first was to get this on the agenda has been such a struggle, and it's also wonderful to be able to have a session addressing this. In Australia, they're working on a consensus statement about which tools to use, and I think we'll learn a lot from there. We already have, work going on in England, work going on in Sweden, but not many other places. So in 2018, the last time the ECDC surveyed 53 WHO European region countries, only 5 reported having done at the national level any HRQOL, QOL surveys, and not even using the same tools or regulating. So I hear your plea. Regarding the time, well, I mean, the waiting room time can be well spent. Everyone complains about the wait, but maybe we can put that to better use. And there they are filling, just like they're filling in many other questions for to get ready for the case history. I think we need to see that visit as not just the HIV checkup, but really more of a health checkup. This is the opportunity to provide holistic care because we have a population that's worse off, and HRQOL gives us those tools to do that.
Dr. Perez Valero.
A short question. I think there are 2 main problems when you try to use prompts on your clinic. The first one is exhaustion. I mean, at the beginning, there are an 80% of people willing to do the prompts, but after time, this number drops dramatically to 20–30%. So, do you have any strategy to avoid this? And the second problem is frustration, I mean, because sometimes you are detecting things that you cannot give an answer or a good answer to the patient about that. So sometimes you are detecting things that you cannot manage or you cannot solve. So sometimes that could be also risky from my perspective. What's your opinion?
Prompts, fatigue, and prompts, frustration.
Yes. No, yeah, I think this is so this is a very a point that we've seen as well in the UK. People with HIV are a very heavily researched group in the first place, and they're constantly being asked to take part in some survey. And even at the clinic level, you ask them to take part in your own survey. It can be tiring if they're seen every 3 or 6 months. I would say this underscores the need for a nice, brief, short tool that can be just a few tick boxes. That's something that you can use repeatedly. I think then if you're looking to collect some data, again, from sort of a national level or to feed into surveillance or to feed into policy, that is something that you would do on a much less frequent basis to avoid this fatigue. So these more in-depth surveys. In the UK, we do our Positive Voices survey once every 4 to 5 years. If I'm honest, that's partly due to limited resource. from our perspective. But it also, and we also take a sample of patients to avoid people being resurveyed over and over. So that's one strategy that we use. So the more in-depth assessment is less frequent. In terms of frustration of things you pick up, I mean, again, I can only speak from the UK perspective, but I think if you don't measure it, then it doesn't matter and you can't do anything about it. So I would be cautioned against not measuring something just because you don't have the service there already. One example of this in the UK, which I briefly mentioned, was we asked questions about needing help with weight management. We also asked questions about BMI. When we fed that information back to clinics, a lot of them found that they had major need for weight management services, but almost none of them had referral pathways set up for that. And this did lead to some of the clinics being able to bid for some funding to get a well-being person to come into the clinic once afternoon a week to help in integrated care. It also led others to build a link with services that could help with weight management. So once you start to assess these things, then you can actually build pathways to signpost or deliver that help in the clinic. You can't be asking the clinician to be able to meet all of your need. You're not a general practitioner, but you can find ways to refer patients out and use that data to build evidence for the need for that. But again, it's difficult because you can't meet every single need. So I empathize, but it's still important.
We have to close, but I think, sorry, but one last question, because I think, and I want you to answer with a number. How many years do we need until we see a graph with different bars in countries comparing the fortnightly?
That's one for you.
Yeah, well, I mean, in terms of how long we need, we don't need very much time at all. We need the political will. So that's anybody's guess. If we're going to get this in a majority of countries around the world, I mean, I don't think we're looking at this before 2025, and maybe we're even lucky for 2030. So I don't like to say that because then it makes people think it's okay to wait, but because we can't wait.
Megan, you see it the same way?
I mean, yeah, I see the same. It's very difficult. It's taken us a long time in the UK to get to the place where we already have that data, you see. So I have empathy if people are starting here. But I think the next 5 years will be really critical. We're building a critical mass and momentum for political will from WHO, from national governments to actually mandate collection of this data. That helps enormously. But it takes time to build these things into the routine running. So, yeah.
Muy bien, pues está claro que la calidad de vida es un tema que nos importa muchísimo y que seguiríamos aquí hablando y que, bueno, hemos visto que todos queremos hacerlo, pero realmente tenemos muchas herramientas, tenemos muchas dudas, aunque hemos visto algunas luces que es como empieza sin esperar a tenerlo, lo mejor empieza a generar información y a solucionar problemas para tus pacientes, y a lo mejor entre todos así hacemos una hoja de ruta y unas guías y que seguiremos hablando seguramente en los próximos años. Muchas gracias a los ponentes por sus magníficas charlas, a mi compañero de moderación, a todos vosotros por la participación, y aquí damos por finalizar la mesa. Gracias.